So the basics are really, yeah, and then also, of course, if you, those of you who are interested in passing the exam, basics, they kind of ad nauseum go on basics. So, does anybody have any, has anybody used any of this in clinic? Anybody, is there any one technique or thing that you say you've kind of taken and made your own, or you feel confident? Confident and confident. Like any one particular muscle test that you feel like you really got it down. The lat. That's good. Good place to start. How about like the psoas? Iliac, psoas, glutes, the biggies. Yesterday, serratus is a real, here we are. I'm going to skip to the, how can I skip to the, oh, that's the nice format.
Yeah, I figured it out.
Oh, good. How can I skip to the very last couple? Is there an easy shortcut way to do that? Other than scrolling through? Yeah, there we go. Yeah, go all the way. There you go. All right. Click on that page. There we go. So, okay, so this slide just, I'm sure I forgot a few things. This basically, everything we have done in the last 2.5 sessions so far. This is what we've covered. So, first section we talked about posture and gait. We talked about basics. These are all muscle treatments here that we introduced our RMAP yesterday. Fascial flush, you remember what that's for? Fascial flush is what you use on hypertonic muscle. A muscle that's congested and tight. That'll be on your test, guaranteed. And when you see a hypertonic muscle with the triad of strain sprain, there's going to be an antagonist that's weak. Usually you find a weak muscle and then the antagonist to that is going to be the hypertonic. That's the typical pattern that the body goes into. And then the synergists are going to be the strain counter-strain muscle. So if you have a strained quad, let's say your rectus femoris is the one that running or something, and the rectus femoris is the main weak muscle by a strain sprain scenario. It responds to spindle up, it responds to GTO, and it responds to O&I. One or all three. That muscle will be how you will kind of get that muscle back online. Then you check the antagonist, which of course is going to be hamstrings. The hamstrings very likely pretty easy to predict most of the time when people have weak quads. So the hamstrings are going to test strong to clear, and then you give them a little quick stretch, test them again, they're going to work. That's a hypertonic muscle. That's the muscle that you want to do a nice fascial flush. Also, I recommend, I don't use fascial flush near as much as I use PNF because it's, I think, faster and works deeper. The same idea. PNF, you're basically helping the patient stretch that muscle by kind of releasing the fascia. You guys familiar with PNF? Some sports people. It's a great technique. It's very simple. It's easy to do. I'll make sure everybody knows how to do it. I think it's, and a lot of times I'll do, and I learned that from David Lee. He used to use a lot of PMF along with measure. It wasn't my idea. It was good. I started doing it. And then you have the synergist. Synergist muscles will test strong and clear, but if you have to do a maximal contraction for 5 to 6 seconds and then retest, it will be. So they're a muscle that's functioning, but they have a narrow margin for error. So you make them work for a little bit and retest them, and they'll lose a step. And that's the muscle that you want to use strain counter strain. Strain counter strain is fold and hold. I find that last. So basically, you find the trigger point area in the muscle, and then it's hard with quads are hard. You have to actually straighten the legs and you shorten the quad. In a short position, you just hold that trigger point. Pretty soon you'll feel a little quiver, or you'll feel some kind of shift, or you've held it long enough and you just retest it, and then it won't then weaken to a following of maximum. So that's what you will find with the synergies. That's the triadic strain spring. So all of these here, fascial flush, GTO, and spindle cell, and ONI, those 4 are biggies as far as treating a muscle that's weak because of a low muscle itself. And then yesterday we learned RMAPI. So you might have a muscle that's maybe it's dysfunctional, and you fix some stuff, and it's passing the test now, but you want to see if it'll handle 10 contractions in a row. Just brain blood. You wouldn't put resistance against it. It'd just be working the muscle, and preferably slow. R stands for repeated, not rapid. So that's another way you can put the muscle to the test after you think you've got all these other. And of course, we end up treating it with ONI. That's usually the treatment for that is ONI. And then we learned category 2. Last session, we learned category 1 yesterday. Sacral wobble, of course, kind of goes with cat 1. We learned up here, we learned about gait testing. Remember gait testing we did last? And plus, gait and plus were the 2 things where we were looking for what muscles they're supposed to. It's another way to ferret out. And then we got into last session, we got into cranials. First one we learned was the most basic inspiration assist. You challenge behind the mastoid, and then treat it on phase of respiration. Usually they need inspiration. Usually it'll be one side or the other, sometimes both. That was the most basic cranial falls that we first worked with. Then we went to steno-basilar, which is basically inspiration assist fall amplified, but deeper and some more stuff. That's where you have to actually go in and affect the sphenoid walking mechanism along with the session. Now, as I'm going through these, if somebody says, I don't remember that at all, or I have no idea what that means, please raise your hand, because you're probably not going to make sure everybody's kind of at least got a working familiarity with these procedures and phenomena. But so far. We also, the very first session we learned sagittal suture. And what muscle is related to the sagittal suture? Rectus abdominis. Rectus abdominis and sagittal suture. Keep that connection in your brain. That'll be a problem, I think. Most likely. Should be. And sagittal sutures, remember, always jam. Unless somebody's been dropping the head. They always need separated. And the normal movement for the bridle bones is what on inspiration? Separate. Separated cytosuture flare. Okay, dynamic challenge and static challenge, also known as direct challenge. All clear on that. This is like one of the foundational underpinnings of it is the challenge. Challenge, muscle test, and pretty much it. What we do at AK, we're challenging the sensory system, and we're using muscle testing. So dynamic challenge works. Does it work everywhere in the body? Works in the spine and rib heads. And because there's a rebound phenomenon due to the intrinsic muscles in the spine. So if you spring a vertebrae in the direction you think it needs to go, spring, let it go, it's going to spring further back into the lesion. And you're going to get a strong muscle build. Also, if you suspect the vertebrae needs to go this way, and you push it that way, a weak muscle may go. But then you want to test it with a strong muscle. If you push it statically in one direction and hold it in the lesion, so you can push it and hold it in the lesion, weak muscle. You can push it and spring it and let it spring in the lesion, weak muscle. That's a dynamic challenge. And those we use in most of the cranials, all of the spine, pelvis, but not the extremities. Extremities, you do not have a rebound. So all challenging that we do to joints outside the axial skeleton are going to be a static or a direct challenge. So if I suspect I've got a posterior tibial head or a radial head, thank you. It's analogous to if I suspect I have a posterior tibial head, I can challenge that tibial head posterior and check a strong muscle for it. I can't, however, push it and release it and do the same thing. Likewise, you might have a weak muscle, and if you that's associated with the joint, and you press it out of lesion direction, make it straighten. But that you wouldn't want to count on entirely. Go back and find a strong indicator muscle and challenge it towards the lesion. That's going to give you your best vector and your best value. So static challenge in the extremities and also in the spine. Dynamic challenge, spine, cranium, teeth, sacrum, but not the hips. Hip joints are going to respond to static challenge. The actual hip joints. Questions on that? I've had questions before. I hope they clear. Maybe they clear on that. Now, we use inspiration, two kind of arenas where we've used inspiration and expiration to see how it changes gaits and finding. Before we even got into cranials, the first time we talked about that was with dynamic change. So if you're doing respiratory correction on the spine, you challenge and you find the vector and direction that is a positive challenge. And when you do that, you have them take a breath in and hold it and see if that changes the weak response. You're re-strengthening the muscle and web. Then you know that you're going to do your correction on inspiration. And occasionally, it'll be expiration. And occasionally, I'll find expiration on, it's weird, I'll be stuff one side of the body once expirate. Yeah. So that always leads me to think that maybe there's some other deeper stuff going on. That's how we use it. So the other arena where we talk about breath in, breath out, of course, we use cranials. And we use a breath in, breath out to screen to see if there is cranial involvement. The muscle is weak and clear, breath comes in, holding the breath in turns the muscle on, there's something. And it's usually in the cranials and maybe the sacrum, but often in the diaphragm too. It's all part of the same. Yes. So the three that come to mind right off the bat. There's some others, but the three that we've covered. So a inspiration assist is just a breath in. Expiration assist is just a breath out. Whether you're doing a dynamic challenge, a forced inspiration, forced expiration is associated with steam. That's the deep set, the SB. Third specific breath is half breath in, strengthening bilateral PMC muscles, bilateral weak and clear, are strengthened by half breath in. That's a temporal movement. And we saw a couple yesterday. They are pretty predictable now. Half breath in, you'll strengthen. Full breath in, you re-weaken. Come back down and they re-strengthen. Same with the parietal. The parietal descent will respond to, from a full breath in, a half breath out. This will turn on a weak muscle that's from parietal descent. So those are the three main cranials that we've talked about. Now, we also talked about the cruciate suture, which is kind of a good thing to do if you're going to, I think it's a good thing to do if you do a sphenobasis. Dr. Leaf used to always say, the first thing he would do is do a cruciate. You just make sure the cruciate was moving, and then you do the rest of the thing. His approach. It also, the cruciate suture is really prone to jamming with tight TMJ function or aberrant TMJ. Now, we just got into fixations. I don't know who, we actually workshop fixations yesterday. Yeah.
Not sure about. It was hard to kind of.
Yeah, kind of.
Yeah.
Almost.
It was just I'm not confident with the fixation because it's not something that I really well.
Well, I want to workshop that this morning because I want you to learn how to find them. So where with subluxations, the way we approach them in AK, subluxation will be revealed with like a two-finger TL to the vertebra, to the spinous process, and a strong indicator muscle will weaken. Subluxation will show up that way without any movement, just TL. It's like energetically that zone is ripe for discovery. Fixation is not the same in that it may or may not TL, but often it won't unless you TL it and then create motion. And that's what will bring it up. It'll bring it up on the screen in your nervous system, your sensory system. That's what we're trying to do a lot of times. The brain has all kinds of things it's trying to process. So a lot of times when we're doing challenging, what we're doing is we're putting that to the front of the lines. The brain has to bring it up on the screen. Oh, we got to deal with that. And that's a lot how I think TL works. There's a lot of different explanations. Pretty good ones. They're probably all somewhat correct about why TL works, but it does work. So with fixation, that's the key difference as far as finding is the way you TL it. The other thing that's unique about fixations is any bilateral muscle weaknesses are fixations. I'll put that slide back up. Because we want to find, and we found some upper and lower. And, but we want to find the associated muscle weaknesses and look for the fixations that that anyway, is that
If we're gonna
help?
workshop it,
So so the way we find them, you're going to learn how to do this. The way we find the fixation is with palpation. And usually you can do it seated or standing, but usually prone is the best. And you go to the area and you just palpate and look for movement. Press the spine right, left to right, right to left, and you look for the one that's stuck. It'll usually be 2 or 3 that are stuck, maybe 4. But you go to the top one of the group and you start pushing back and forth. And if it's, say it won't go this way, you're assuming that it'll go this way, but not this way. Then you go to the, over the facet TP areas, and you spring it this way and spring it that way. If it feels stuck on what we would assume is the posterior side, and this is the tail, then you're going to adjust that top vertebrae. It wants to go this way, so you're going to be over here trying to help it go that way, and then you come down to the bottom of the compass, and you basically stabilize it and adjust this up. That's how we adjust it. It's probably a lot the way you guys are talking. Basically,
Skip the first part.
yeah, you just go with palpation.
Yeah, we go straight to the TPs.
Yeah. This may help you dial it in more precisely. And now, if, say, left to right is stuck here, but it isn't stuck here, it's stuck here. This TP is jammed anterior. Then you go down to the bottom of the compass, 2 or 3 down, and you adjust the bottom one off the middle. What you don't want to do is you don't want to further anterior, put any further anterior force on it. So that's how we adjust it. Subluxation, how do we adjust the subluxation? Same thing, we spring around and it kind of feels kind of goofy. So you kind of spring it and you use it as a dynamic challenge. And then that determines your vector on that one vertebrae. Subluxation, we're just adjusting one vertebrae. The fixation, we're adjusting the same. What else can I tell you about fixation? Is that, I mean, you'll get to do it, but.
Can you say that one more time? The fixations you're adjusting.
You're adjusting, let's say 3. It's 3 or more vertebrae. Sometimes you can have 6 or 7. But there's always 3 vertebrae involved. Subluxation is 1. Now you could have 2 vertebrae in a row that are subluxated. That's a pretty nasty problem. But subluxation is actually 1 vertebrae.
So like a fixation would be when someone needs to get their back up and they've got like 4 anterior brain pockets.
Yeah. You the classic kind of roll over the, up the tube kind of thing that we all do. I think the osteopaths really should be credited with that particular. It's one of their contributions to the world of manipulation. But you're just grabbing a handful, and you're clearing fixations. But this will, and you might still adjust in the same way, but at least if you use this protocol, you'll really know how it should be adjusted. That's the same with subluxations. How do you determine how to adjust a subluxation? Well, in the old days, they'd use x-rays. There's still chiropractors who use x-rays. Palpation. But with AK, you can determine exactly how that vertebrae is affecting function, not just the position of the vertebrae, tenderness and all that. You can actually check in real time how it's affecting the rest of the body. And then once you've adjusted it, you can determine if you is what you did really made the correction. Anyway, so fixations. Any other questions about that? Really, really, really important. Ileocecal valve, we just started. Lymphatic, we're going to talk about here in a little bit. One of the reasons that we introduced PEC minor in this session is that we also introduced the lymphatic. It's called retrograde lymphatic, which is a way to kind of help clear your patient's clogged lymphatic system. A lot of lymphatic system is really advanced. And yesterday we learned about compaction. So the triad of strain sprain, injured muscle, weak, response to spindle up and ONI, antagonist, tight, congested, response to fascial flush and PNF, synergist, fused, trying to help out his cousin, respond to strain counter strain. That's the triad of strain sprain. Compaction is, somebody tell me what is the thing, what would make you suspect compaction around, say, a shoulder? Very good. Acceptable. All muscles weak, acceptable. And the one muscle then you can test with the technique we did yesterday, which is
The RAM.
RAM. Yeah. And then it's going to respond most often to ONI. Not the CASA. CASA. We jerk. And then GTRs, that's something that's tacked on today. It's a kind of neat little neuro trick to find deeper. Kind of like plus is. Yes.
I don't think we did a full strain.
That's why.
Everyone had a compact.
Anybody in here have recently screened? I know I asked this yesterday. You know, maybe you did something in the last 24 hours. Yes. You did what?
I said I straightened my toe.
Straighten your toe. Yeah, that might be tricky. I mean, that would be fun, but
Like a rolled ankle.
roll that. Yes. Left shoulder. Do you have a history of injury? Anybody ever had whiplash? Okay. Good. Yeah, good. Oh, thank you.
He wasn't asking.
Yeah. Whiplash is one of those terms that all your patients know, kind of like lumbago or ACL. Everybody knows ACL. Or do you think it's my ACL? Or my rotor cuff? My rotor cuff. I love that one. So this shoulder.
My shoulders are also really unstable, like sometimes I pick up in the middle.
They feel like they're,
It feels like they're just like crashing.
oh, okay, like this.
Yeah, like if I fall asleep on my side, sometimes I'll wake up.
Tell me what I'm testing.
Deltoid.
Which one? Yes. Now what am I testing? Posterior. So, okay, so tell me what I'm testing. That's not stable. Is that painful?
No, but it's just difficult.
You come halfway down. So right there is cutting your weakness. That's not a great. Let's do your round one. Let's do your pack. So.
Like just moving.
I'm going to bring it down a little bit. That's a week. Do you lift weights or do anything?
Yeah.
So that's
One of like load bearing.
for.
I do a lot of yoga.
So what I'm going to, I heard infraspinatus, which we haven't really done this year yet. But infraspinatus, this is how I test it. Now, you'll see it tested this way, and that's fine. See right there? It doesn't really show. It's a little mushy right there. So I'm going to assume, I'm going to just take a leap of faith, and I'm going to assume that the infraspinatus is my primary muscle. And I'm going to go into that infraspinatus and spindling from the center out, which does what to the turns it on. Spindling from the center out turns it on. Spindling towards the center will temporarily off. So I'm I know we talk about just doing this, but I get in there and just really spend a little time going through those fibers, make sure that all of those, get as many of those receptors as I can get. Then you retest, push. That's better. It is better. So that's on, but it's going to turn off again because we haven't addressed the rest of it. Now, what's the antagonist of the infraspinatus? So we have subscap and probably lab a little bit, but especially subscapularis. Now, this is how we test subscapularis. And it tests strong in the clear. I'm going to give it a little, and it goes weak. So that would indicate what? Hypertonic, which indicates what kind of treatment I want.
Fascial flush.
Okay, so then let's do that. We'll just do that real quick, and then we can proceed and we'll check the synergies. So the subscap, you guys can come here. Gather around if you want. So you're only going to get at an hour and a half or so. Sometimes I'll take the patient's arm and I'll just kind of traction out. And that gives me a little more room to get my fingertips in. Make sure your fingernails are nice and straight. So I'm on the outer edge, outer half of the subscap. Is that okay? Now, the only way I can really fascial flush it is just to kind of push into the muscle and then move the kind of moving. By doing this, I'm actually lengthening the fibers, right? Fibers shortening. I'm trying to, the muscle does this. I'm doing more pin and stretch kind of fascial release. Is that okay? It's getting less tender. It's getting less or less.
Maybe a little bit.
Okay. I can feel it kind of change. It just changed.
This tissue is special.
Yeah. Now, one could argue a lot of people in body work would argue that the tight muscle is the same problem and make a really good argument. As long as that muscle is tight, it's going to be resulting in inhibition of antagonist. Okay, so, okay. Now let's just push. Not strong before, but I can weaken that actually. Yeah, so we got that. Now we need to sit up again. So we took care of the primary muscle, the spindle. Try to keep it as simple as we can. We fascial flushed its antagonist. Now we need to look for some synergists. So what's a synergist to a things? Teres minor would be the top of this. So infraspinatus we test this way. Rotator cuff muscle. Teres minor we test this way. Rotator cuff muscle. Subscapularis motor cuff. And what's the fourth of the fourth and final? Sits. So that's strong and clear. Then I'm going to ask you to just hold there for about 6 seconds. 1,000. That's good. Now let it relax for a second, and then go back to the muscle again. So that fits with our. Now the way I treat that is I go to the teres minor, way up there, and I'm going to get right in the middle of it, and then I'm going to allow the fibers to approximate. And
Yeah. They're a little unstable.
Now just go ahead and breathe normally. Dr. Francis always said it helps to make sure that he thinks it helps to have the patient hold their breath. Like, I'm not sure, I don't know. But it sped up the process. Now I'm right on that muscle. I'm waiting. I want to feel a little twitch or maybe a little shift like I did with the subscapularis. Okay. So push. Good. Now hold for 6 seconds.
I feel like I'm recruiting less accessory.
Good. Good. Now that relax. Yeah. So it doesn't go deep. So that's a very really great example of triad-strain swing. You could apply that. It could have been the primary muscle. Could have been the delta. Could have been, often it's a pec. Often a pec is the primary injured muscle. And then of course, rhomboids, sometimes I see a lot of tight infraspinatus. And one of the first things I do when I'm checking a shoulder is I see how their range of motion is here. A lot of times they're like there. And you can spindle down that infraspinatus, and a lot of times it'll just drop right. Then you know that's a good. You know it's been tight. You know that's a good sign. But anyway, thank you. That was now just move that around. See if that's any here.
Yeah.
It should. Yeah, it should feel just fantastic. Tell your friend. So, straight sprain. Who asked that? Somebody said. Weakened after 6 seconds. Get both approximated. An easy example of holding the jazz like a bicep. This case, called the teres minor. Testing position and the straight counter strain. Then afterwards, it tolerated a 6-second contraction. No, I was right in the muscle. That's the triad. Now compaction. Who had compaction? Yesterday, somebody had a compaction in their ankle.
Oh, Nicole, she's working.
That's right, you had it in the hip. That's right. Can we recheck and see? Because that was a pretty. I can't remember what all which muscle we.
Everything was off the glute.
Hamstring, that's right. And it weakened the RMA. Yeah, that's right. Which side was it? This side?
Yeah.
In
Now
my office, I've got my iPad with my notes, so I can glance at my notes and I don't have to ask people which side they're. Chat, what am I testing? Cheat test. So,
TFL.
Yeah.
yeah. So as,
Yeah.
there, what am I testing? Okay, now what am I testing? Very good. Everybody got that? What am I testing? What am I testing? Everybody got that?
What was the last one?
Now, how would I test for hamstring? Put it in neutral. And then you rotate the tibia in. And now you use your outside arm to kind of changing the vector. That does make a difference. And especially makes a difference for just the comfort of the tester. And that's good. But it was good yesterday, remember? Shut down. That's weak. That's weak. Cheap adductor test. Weak. Now, what was the criteria for compaction? Yeah, what else? What makes all those muscles turn on temporarily? Traction to the joint. Traction to the joint. Remember, compaction. So you give it some traction, and oh, that's better. Body goes stiff with that. Right. That's how I pass tests. Weird little things. For songs, song lyrics. So I'm going to give you just a little tug. But move again. We had that yesterday too, right? So something they now push out. So that turned on. That turned on. This was. That was strong.
Strong already.
That was strong. That was not too bad. So as was weak. So as is back. Iliacus is back. Now the hamstrings, so do 10 reps. No, it's good. How many is that? So what should happen? And they did. So that's the same thing we fixed yesterday. So back. We fixed it with O9. So something maybe you need off the cost. I don't know, but yeah. So it wasn't quite as. You just have to.
I have one thing about
Okay.
unless I took my degree. I don't think it is.
Doesn't need to. So you have which ones are you on? You know. I don't know. I mean, right now, we could go back in and check that. Let's just check real quick. That was the hamstring point we were trying to right? Still. So that it is, and so then I'm thinking, maybe there's something going on with their knee. What am I testing now? The week yesterday. Who tested her?
Yeah, it was me.
Both weeks.
Because one of ours was weak, because he didn't yours.
Now, both of hers are weak. This is the perfect segue.
Oh, great.
Do this right into the middle of your cervicals, and I want you to move your neck. Yeah, just kind of give it some motion. And hold. Difference?
Yeah.
This is perfect. There we go. So she has a mid-cervical fixation, and that's where the bilateral is in the fixation. So you have a bilateral cervical fixation.
So would you adjust the cervical?
Yes, I would. But, yes, I would. I'm not going to pop it.
You can do it.
I will do it very, very gently. I don't really know your neck. And And see, she's really, she's pretty stretchy. Yeah, right in there. It's kind of like, it's kind of stuck this way. Just gonna very gently, just kind of, see that it may just open up, stretch. That was a little bigger. Now, we want to, at some, I mean, we'll see, this should, yeah, they come right back on. But then, there's something going on that's allowing your cervical, maybe just all the studying or whatever, that's allowing your cervicals to jam. So, sorry, do the 10 contractions again, yeah. The bilateral popliteus weakness, check for a cervical fixation. Now, they may not have it, maybe they have 2 bad knees, maybe the neck's fine, but always check for that. Very often, that's what you find is that. Yeah, so,
Guess I need my neck out.
yeah, you just need a good old neck. But probably, okay, so since we're there, bring your head back. Remember for yesterday? They're not down. They're not big down. Check your flexors. Am I testing? What am I testing?
I see.
Those are good. Right now, of course, we just adjusted you. That. Cool. So there we had compaction, then we had bilateral. A perfect example of bilateral muscle is related to a thing. So, shall we? Does anybody know reflex hammer? Oh. Since I've got you all here, I'm going to show you DTTR. Who has normal DTRs? Who has a good set of DTRs? Lay on your back. There's 2 ways that we 2 areas. One is the classic tela reflex, telar tendon reflex, and then of course the biceps. So Dr. Belli, who just recently stepped down as our president of the ICAK USA, he came up with this years ago, and he found that if you hit the reflex, you will get a short-term change in the antagonist, and also on the muscle on the other side. So, for example, if we use the quads, we'll just make sure. So just make sure I'm not dealing with So if I do a reflex here, there's going to be weakness of our hamstrings because of the reflex arc and because of the cross crawl pattern. Let's test your hamstring first. So I have a baseline pull. So if I trigger her reflex and then test the hamstring, it resets. If everything's normal, it resets. And also, if I let's see what's the other one. If I do a push. So if I do that reflex and test the opposite quad, it goes weak. And here's a normal. If it doesn't, what happens is it'll just keep going weak. It's like it doesn't reset. That's where he would go then and try to find what, it would help him find other subluxations and other. You know this hamstring strong. Yeah. So if I trigger this, pull back. Those weak. So you're completely normal. If that didn't work that way, then I would start TL to where I would go occiput, upper cervical, to where the dura attaches. That's right there. Usually you'll find it somewhere. Usually it's a C3. Thank you. That's deep tendon reflex. It's just one of those kind of finishing things, kind of like the gait where you're finding which muscles are inhibiting, and if they aren't, then it kind of. This is another one of those things. This is easy to do because you don't have to. Some people are, they're kind of hard to get.
So that takes you what, straight back to the spine? then?
Takes you where the dura attaches, and then all points in between. C3, L3 was Dr. George used to always break. He always thought L3 was even that one. But Dr. Belli is one that came up. So let's all do fixations and ICD. So somebody come up, maybe does or doesn't have. Sure. And then I'll get the slide up with the bilateral muscle. So we're not looking at anything else. We're only screen to see if she has probably rising. So first I'll find a muscle test. And I might just go ahead and test the iliac axis. The rectus. Anything that's small or large intestine related can be affected by that. So then I'll have you basic TL. Now, maybe she's got a problem with her rectus femoris. Maybe that TL was just enough. So I'm going to move her hand more specifically over. And notice. Now, that creates a weak muscle, a weak, strong indicator. Now, if she might have had a weak iliacus, that might have strengthened that. The way we got there now is we use a strong indicator muscle, TL. You sleep last night? So the TL weakens the muscle. Now we want to find out what re-strengthens it. TL weakened it. We're going to pull down and try to get a capture, push towards the opposite shoulder. That's closing the valve. It's going to encourage the valve to close. And re-strengthens. So that valve is open. Closed up. Now, you can just be on ring and go the other way. And still weak. So just a straight TL with no direction, no traction. Find out what strengthens it. That love the first time, press it up, close. So that valve needs to be, that part of the hitters needs to be. Yes. There's a couple ways to do it. I mean, ultimately you want to do manipulation. But then you also want to check for kidney core on the right. And sometimes it is, sometimes it isn't. Sometimes it's just split there. It's a tender area, anyway. Bladder 58.
So, bladder 58. So more on the right. So I'm going to, now, will bladder 58, he's caught. See, if I just touch bladder 58. So, also we would check, because it looked like an open, we would check for a temp. So that's one of the Chapman reports. And then another one is right behind C. Possibly. I mean, it depends on why the valve is open. Lack of tone, neurological tone, and the adjustment micro. Well, sometimes when I'm doctor TLing, which I have less of a strong connection with, it's always, it was, you have enough energy and I've got enough break. But sometimes synthetic fabrics can TL effect. So to correct it, one way to do it is have a patient. I don't do this too often. I show them how to do this at home. So you keep that right there. And then I'm going to go down here and hold. Actually, can I pull this off?
Yeah.
Oh. There. You got some serious footwear on here. You're ready for high water. Yeah, it would have been, what, when they had the flood in here? How high up did the water get? I like this floor. It's more interesting. It feels clean.
Yeah.
Carpet just hides all kinds of unspeakable
Hasn't changed since I was in here, so that's over 10 years.
So some of your skin cells would probably be underneath that part.
It's not right over there. 6 hours a day.
Forensics can probably find your DNA in that part. Probably find mine too. Letter 58. So that's usually more than that.
With the ICD, are we sure that it is pathologic? Like, what if she's just digesting right now? I want to test.
You know, sometimes I think I do catch them when it's kind of normally, because I check it on almost everybody.
Didn't eat anything.
But I don't know that really ever. I think if the valve is dysfunctional, you'll have to use it.
You're testing like if it's stuck open or if it's stuck closed. That would be like a function, which would show the TL if it was just. Then you're probably not gonna find out.
And if it's stuck open, wouldn't we expect SIBO?
You would expect like diarrhea, right? Things are going through faster. Usually, closed would be more of a constant.
Okay, so you're looking
But
for
then,
bilateral
yeah,
muscle
it would
weakness, but I'm not finding it. Exactly.
How long is it?
Okay, I'm testing delts. I'm going to test your testing for miss. Little. Yeah, spleenish. Now I'm testing what? They're all weak. So the lower one indicates lumbar fixation. So can you? I'm just going to motion that, and you put your hand right on. Oh, no, I need to. So that turns on. There you go. Yeah, so that negated the weakness. So that shit, the thoracic lumbar fixation, affecting bilateral lower tracts. And you're fixating the ears. You get adjusted right now. I just
Well,
very
can
gently.
can you show how you're challenging what you're looking for? Because I think that's the biggest.
I will, but I want to do something else. Yeah, we'll go. For sure. Can you, actually, we might be able to test the muscle test. Because we went from, the weak muscles turned on. I want to find a strong indicator. See if we can, now go back to the thoracic lumbar with both hands. Now, so we get a positive, so I'm verifying it with a strong muscle. It's kind of hard, but can you touch your upper back? Around. Yeah, that one doesn't really show. Lay face down, and now I'll show you what Dr. Whitney's talking about. I'm hoping you'll find. So so the first thing we did is we went off bilateral muscle weakness, and we got positive TL. And we know that bilateral lower traps is, so I know that my fixation, or at least I'm pretty strong, assured that my fixation is somewhere. So I don't have to, just check the whole spine necessarily. So I'm going to start up here with about T11. I'm just going to take kind of a broad, now, just kind of looking for right there. Yeah, right here, and see that stuck. It's like it's this way. So spine is stuck, spine is gives, spine is stuck. So it's either stuck here, that roll backwards, jammed anterior. That's the two ways. Now the bottom part of the complex is actually right there. A little stuck. So I'm going to go to this set, and actually doesn't feel that stuck to me. It feels kind of springy. That hurt. So I'm going to go to the anterior, see if it's in. That hurt. And that's a little, either one are super stuck. That one's stuck right there. So I'm going to go down to here, the bottom of the complex, and because I want to adjust this up and this down. My adjustment is going to be like, it's just a real basic. And breathe out. And I'm holding the top one and I'm just pulling the bottom one. Didn't pop. But we'll know if we got it by the muscle. I don't worry anymore if it doesn't. Just to think, and it doesn't pop, the patient's not going to think money's worth. See, that's strong. So I'm not going to adjust it again. That made the change. Now let's see what's happening there. And I'm doing the middle. And that one's turned back on too. So now, this feels kind of niche to me, but it doesn't necessarily mean it needs kind of an extension. But it doesn't necessarily mean it needs adjusted. It just, to me, it feels stuck. And this rib is a little. Now, that's going to be more subluxation. We touch here. It's TLing that vertebrae. So that's a subluxation. Now, It's actually, no, it's like yeah, yeah. So, so how would we adjust this? It's a subluxation, not a fixation. Fixation, we did the way we did it. I think the rib needs to kind of roll this way. It feels like that. But I'm gonna let her body determine if I'm right or not. Hamstrings intact. Oh, thanks. So I'm just gonna get on that rib and I'm gonna spring it down the way it feels like it should go. And it's not. And then I'm gonna go out, see if it just needs to come out a little bit. And it's more, yeah, okay, so I'm gonna come out and slightly superior, even though it doesn't. And that said no, so out and inferior, and that's there, that's what we want. So take a deep breath, hold the breath in, hold. So it's an inspiration assist. That, everybody with me? Session 1. I did like 3 challenges, and a couple of them didn't show, and a couple of them didn't. And the one that really turned it off was sort of out and not straight down, but out and down. Breathe in. Let it go. So breathe in. A lot of times ribs will just kind of ride their breath, let their breath kind of guide. Breathe in. There we go. She's still really tight in there. Once again. Good. Okay. Give it another breath. And I'm just going to give it a little adjustment. Sorry, it started. Let's give it a little extra.
Did a rebound challenge.
We did a rebound challenge, yeah. The rebound challenge ended up being lateral and inferior.
And that's why we said that.
That's why my exact vector correction was exactly like me.
Yeah, I'm sorry, you got a rebound.
Yeah, so what I did is I went spring, 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 let it go. Still there. We didn't. Rebounding into lesion. Well, it still wants to go that way, but it didn't move. No. Adjustment didn't go. So I'm going to come up underneath it and just see if we can. There it is. Challenge. Oh, that got it. It was just kind of halfway. Okay, that's better. Yeah, that's better. You're really tight here. Like this muscle right here needs serious work. What's that? What? Well, no, somebody should probably get in there, or you can do it on yourself, get a tennis ball and just start really working. Because remember yesterday, the neck extensors, they come down clear to T6. So they're yanking on those facets and fascia and everything. We're doing our studying and our driving and our stuff. So thank you. That was so we had fixation, we had ICV, an open ICV, we had a subluxation, and we had a rectal lumbar fixation, and then we had the mid-cervical fixation, bilateral. So there's 2 examples. So I'm going to bring that slide back up, and you guys will look at fixations. And scan your patient for ICV. But just try to do those fixations in that order.
Yeah. Really hard. Pretty intense. Yeah, actually, the back, I don't, for some reason, my account, and it keeps me out there. So I tried, and I was like, I know you I wanted to see like I just
I know, like, I feel like once